This is the next step in our attempts to try to give our medical staff as much information as possible in dealing with the ever changing needs that we see in our hospital, and our goal of treating people exactly the way that they want to be treated and appropriately. We are happy to have an expert in this area to help us with the presentation, and there will be time for questions afterwards. We have Dr. Olson. Dr. Olson is a adolescent medicine physician specializing in the care of gender nonconforming children and transgender youth. Dr. Olson has been an assistant professor at Children's Hospital Los Angeles for the past 9 years, and providing medical intervention for transgender youth and young adults, including puberty suppression and cross-sex hormones, for the past 6 years, and is considered a national expert in the area. Dr. Olson is the medical director of the Center for Transyouth Health and Development at Children's Hospital in Los Angeles, the largest transgender youth clinic in the United States. Dr. Olson has appeared frequently on national television and spoken all over the country to educate providers, parents, and other communities about the needs of transgender youth. And obviously, that's what we have her here to talk about. We have them here to talk about. So we're very happy to introduce Dr. Johanna Olson. Thank you, Dr. Olson, for being here.
I've been doing this work for 16 years. I'm actually an associate professor now. So just as a little update so folks know, I am notorious for having more content than I have time. So if I'm moving really, really fast, just please raise your hand or interrupt me if something is confusing. So some folks know I do a 14-hour training on this care, so squashing it into 90 minutes is a bit of a challenge. I want to talk a little bit about start out by saying something about trans visibility in the US, to sort of talk about why we are having this conversation here today and why I am asked to do so many trainings around the country. I think folks know that for a long time, trans visibility in the US looked very, very specific. And there was a study that was done by GLAAD, who is responsible for the LGBT content in media. And they did this study where they looked at 134 episodes of TV episodes where a trans character was brought on. And what they found was the most common profession that they were brought on to portray was a sex worker. And I think this is a very common sort of scenario that we see, is usually trans women of color brought on to portray sex work. I think this is the other manifestation of the way that people talk about gender or gender expression. I love Priscilla, Queen of the Desert, but I think these are very narrow perspectives about the experiences of gender nonconforming people. And then Boys Don't Cry. So the palette upon which we, as cisgender people, but also as trans and non-binary people, have seen themselves reflected in the media has been inadequate historically. I think what's exciting is that we've seen some new presentations or documentaries about people. These are our children, and I think these stories have caught people's attention as well. So some folks may know this kiddo is named Ryland, and he was designated female at birth. He was born with hearing loss and congenital hearing loss. And as soon as he got cochlear implants at the age of 4 or so, he started saying that people had his gender wrong. This kiddo was on the front of National Geographic in an issue that was devoted completely to gender. Most people know or have heard of Jazz Jennings, who is a transgender young adult whose life has really been profiled on a reality TV show. And then Gavin Grimm, who is from the Midwest, and he actually sued the school district to be able to use the correct bathrooms in a court case that went up to the Supreme Court, and he eventually won. Also, we've seen an uptick in the numbers of trans actors and actresses playing trans roles, which is really exciting. Not just that trans characters are embedded into dramas in a way that is very dissimilar to how it has been done historically, but that the roles are being portrayed by folks from the community, which is really important. So in all these ways, young people and adults as well, but because I'm talking about youth, I'm going to specifically focus on youth, have been able to see themselves reflected in the kind of media that people consume on a daily basis. So that's been really exciting. And despite the increased visibility, I think we probably all know or have heard of, the myriad of young people who we have lost to death by suicide related to their gender dysphoria. And this is only some of those young people. I think that it is important to recognize that, we are still losing young people to death by suicide related to gender. And so we really shouldn't be losing anyone for this reason. And so it's for these young people and so many more that, we continue to carry on with this work to provide services that are really timely and appropriate for young people. So a little bit about our clinic. I think you heard in the introduction a little bit about the front half of my career, but it's important to know that we've been providing this care for trans youth since the mid-90s. We started tracking new referrals in 2010. I have been doing this work since 2006. So shortly after I arrived, we started tracking, and you can see, not dissimilar to many clinics across the US and in Western Europe, we started to see a substantial increase in around 2015. And it's been going up since then. You can also see in those turquoise bars are people who are designated female at birth and identify as transmasculine or male. In the gray bars, people designated male at birth who identify as female or transfeminine. And then the darker blue bars at the top are people who identify as non-binary, genderqueer. And so the ratios, obviously clear increase in people who are presenting with non-binary gender identities, and then an increase in the number of people designated female at birth. And so these are similar trends to many clinics across the country. We have about 2,000 young people in active services between the ages of 3 and 25. And they graduate into adult services at 25. So I want to talk about the lexicon of gender because it's ever evolving, and because it is being evolved, it is being pushed forward by trans kids, young people, and cisgender people. But I think it's really helpful to be on the same page about things so that as I talk about them, it's not that people don't have different ideas of what I'm talking about. I created this gender abacus to kind of explain some of the domains of our psychosexual selfhood. And we're going to go through some of those things to set a stage here. So our designated sex at birth really comes from either our knowledge of chromosomes or genital anatomy. So when a baby is born, if said baby has a penis, they get a male gender marker. If they don't, they get a female gender marker. And I think it's always important to think about how we think about anatomy and genital anatomy, because it plays a role in the way that young people develop. So what you don't usually hear is this person has a vulva, therefore they're a girl. What you hear is this person has or does not have a penis, and that plays a role in the way that we understand ourselves. And sometimes people have information from an in utero ultrasound, and sometimes for various and sort of reasons, karyotyping in order to determine maybe some chromosomal, to rule out chromosomal abnormalities, et cetera, give us information about the sex chromosomes, which are down here in the bottom. You always see them in the bottom right. They're the last of the 23 pairs of chromosomes to be reported. And people with XX chromosomes are usually given a designation of female at birth, and people with XY chromosomes are given a gender marker of male. And there are lots and lots of variations of those sex chromosomes. So I think we think primarily of these two types, XY and XX, but know that there are multiple other variations, which sometimes lead to differences of sex development or intersex individuals who may be identified at birth because of ambiguous genitalia, but they may also have been identified in utero by chromosomal analysis. We're not really talking about intersex folks today, although there is definitely crossover in the community. So what is gender identity or gender is a person's internal basic sense of being male, female, both, neither, something else entirely, as experienced in self-awareness and behavior. And we'll get back to this too. It is most often the case that if people are designated male at birth, they also have a male gender identity. That is true, and probably about 99% of the time. But we know that that's not 100% of the time, because that's why we're here today. Oh, and similarly, just before I move from the slide, it's also true that people who are designated female at birth are 99% or more likely to have a female gender identity. Our gender expression is basically described as the way that all of us act to communicate our gender within a given culture, within a given time period. And I really appreciate, you will hear me smattering throughout this presentation, information about history. I am absolutely consumed with the history of the community, not just the community, but the history of the provision of care for the community. And we only really started developing synthetic hormones about 100 years ago. And so in the late 1800s and early 1900s, when this experience of being trans was being documented in Europe, this particular quote from Emanuel Herman, clothing is the unconscious language of the spirit and clearly expresses itself all the more when the tongue is condemned to silence. So in 1910, the way that people had to do their gender, if they were trans, was really through their clothing and their occupation. And so this really speaks to the importance of clothing at the time for people to talk about their gender to the world around them. And here's some examples. So this is from a book called Not Straight from Germany. And this is sort of the way that in 1930 talked about, Parisian male transvestites living as women. So just some trans women on the left side. And then the way that people talked about folks' experience is anchored to their designated sex at birth. So now we would say these are trans feminine people on the left, trans women, however they would identify. And on the right, we would say trans man or trans masculine person. But back then they would have said this female transvestite is Lottie Ham, the director of the Women's Club Violetta. So gender expression is also most of the time aligned. So if someone is designated male at birth, it is most likely they will have a male gender identity and that they will want to express that in a masculine way. And the same for someone designated female at birth, they will most likely have a female gender identity, and they will most likely want to give cues to the world that they're female. But I do want to talk about the importance of gender expression perhaps being one of the most variable and fluid elements of this abacus that we're creating here. And we have a lot of cues in the world about how to express our gender, even when we're very, very young. So if you do a Google search for boys' toys, what you will see is tractors, military things. If you do a search for girls' toys, you'll see kitchen, makeup. This is like a baby changing table, right? So there are still a myriad and endless number of gendered commentary. Also with clothes, right? This is if you look up boys' clothes, the girls just love me, or mama ain't raising no fool. And then if you look up girls' clothes, these are very exaggerated feminine expression ideas. But I'm not suggesting that everybody engages in these particular things, but I do think that the role of consumerism plays a big part in the way that people learn the expectations for how they should be expressing their gender. And that plays a role in how people land as adolescents. So regardless of whether we are trans, non-binary, or not, we are being raised in cisgender normative environments, right? So this gendering starts early. Maybe we get information from an ultrasound. Maybe we have a gender reveal party. Maybe we create, an environment that we feel like is appropriate for the genitals of our child. Buy them appropriate toys, put them in appropriate clothes, and then reinforce all of it with our very common media experiences like Disney. And this isn't to suggest, like, many of us participate in these things. We do it consciously sometimes, and we do it subconsciously and unconsciously other times. My point of saying this, though, is that when we're thinking about the way that people's brains develop and why you may be seeing them within the context of your clinical practices, is it's critical to understand the experiences of people as they're growing up. And these things don't stop in childhood. We have a lot of assumptions about gender based on social cues. Just some examples here, right? This person has a bag. It's probably for carrying personal items, maybe their phone, maybe sunscreen. This person has a bag. It's probably carrying their personal items, maybe a computer. And there are clear, you would not expect a person that is a man to be carrying this bag on the left necessarily. Here's a coat to keep the person warm. Here's a coat to keep the person warm. These items are serving the same function, but they are designed differently. And the expectation is that they are going to go with different gendered people. And in my work, where I am focusing on medical interventions to help people achieve phenotypic congruence with their gender, thinking through some of the physiologic cues on humans that are different, that may trigger someone to be perceived as male or female. Like, in general, men have a more forward-facing brow, which makes the eyes appear set back more. Of course, the presence of an Adam's apple is usually something that might get someone perceived as male. More square jawline. There's a longer distance, for example, in men between the bottom of the lip and the bottom of the chin. You can see in people with ovaries that the presence of cleavage might be one of those giveaways. So thinking about that as people are seeking medical interventions becomes really important. So I add in, as this fourth domain, sexual or romantic attraction. I think it's really important because it is often conflated with gender identity. And the easiest way to sort of separate these things is that gender identity is who someone is. Sexual or romantic attraction is who someone is attracted to, from a romantic perspective or a sexual perspective. I think it can get confusing if people are using language that we're familiar with, like gay or lesbian, because oftentimes people don't understand how to anchor that particular identity. And so if someone is anchoring to someone's designated sex at birth, they may make an incorrect assumption about their sexuality. So what we are talking about today are people who are designated female at birth but identify as something other than female, and people who are designated male at birth who identify as something other than male. Let's talk about this language. Cisgender. So for a long time in this field, people talked about trans experience as like, there's biological men and trans men, or there's real men or real women and trans women. And obviously that's problematic with the language. And so in order to provide more accuracy, this language of cisgender comes from molecules where there are adjacent portions of the molecules. And so that's a cisgender person would be someone who is designated female at birth and identifies as a girl or woman, or someone who's designated male at birth who identifies as a boy or a man. Trans, and the molecules are across. So someone who is designated male at birth identifies as a girl, woman, somewhere on the trans feminine spectrum, or non-binary. Or someone who's designated female at birth who identifies as a boy, man, a trans masculine spectrum, or non-binary. Because that's kind of just a basic language issue. So what is gender? there's all these things that are postulated. Is it chromosomes, reproductive tract, genitals, role of rearing, a socially constructed definition? Is it a legal designation? Gender is very much like an onion. It's multi-layered. It sort of seeps into all these domains of our lives. And I think that gender is one component of somebody's sex, right? Which is this multifactorial part of our biology, right? So what's incorporated in sex, certainly our chromosomes, certainly our reproductive tract and our genitals, but also our gender. And so I think it is easy to understand why, historically there was kind of a trope, I guess. It wasn't called a trope, but back in the 70s, there's this idea that you could raise someone in whatever gender role that you wanted, obviously not willy-nilly, but in examples where, for example, maybe someone had a botched circumcision is the most common story that we hear, but the assertion was you can raise anyone in a gender role and that will be their gender. That's obviously false, and it's been proven false for a variety of reasons, but the most compelling evidence is that most trans people are raised in a role that corresponds with their designated sex at birth, and that is not their gender. And so that's been tossed by the wayside. So as I was saying, when do we begin to gender? Very early. In this karyotype down here, you can see that this person has X and Y chromosomes, and these other 22 chromosomes represent somatic portions or parts of our body. And so the other 22 pairs of chromosomes are responsible for other aspects of our development and our personhood. But X and Y are really the two chromosomes that are responsible for our genitals, our reproductive tract, and they are the determiners of the way that our in utero bodies develop. And we don't have a lot of information to date about how sex chromosomes may play a role in our brain development. So you get this information, and then maybe you have a gender reveal party, which is actually a genital reveal party, which is kind of weird when you think about it that way. But these are very gendered experiences, right? So they're not just bad for trans and non-binary people, but they also are very gendered in their ideology, right? So guns or glitter, what's in the oven, a sweet little cupcake, a handsome stud muffin. This one is anatomic, wheels or heels, team stashes, team lashes. They're just going to eat the baby in this one. I thought this would be a fun party, but not for the reason they think. But all of this does happen. And then again, accordingly, we may put people that have XX chromosomes or, don't have a penis into this kind of a room. And maybe if they do this kind of room, right? So we are engaging in this process when people are infants. And gendering is really ubiquitous. So if you start looking for it, you see it a lot. This was something that I just pulled up rather recently. I thought, I wonder what, the recommendations are for back to school supplies. And even just looking at these things, on the quote unquote girls back to school supplies, there are, makeup and jewelry, nail polish is part of the back to school supplies, and there's a tumbler, so at least girls get something to drink. On the right side, you see that there's a food for boys. Boys get food. I think these are these messages that people embrace, and we are constantly seeing, and young people are seeing as well. So most people aren't really thinking about it, but when you start to think about it, it's very obvious and kind of weird too. So I can tell you, like, there are things that are just so ridiculous. I take pictures of things sometimes when I'm in stores just so I can have them for slideshows. But, there aren't really, I've looked in a lot of people's ears. There's not really a big difference in people's ear canals, like women's earplugs or skull screws, right? So these are some of the things that you see Bounce for men and those who smell them. You know, this is tape just for girls. I don't really know what's wrong with our fine motor skills, but we don't need special tape. This is, you know, attributing gender to the way that people eat. And all this is, I put this here because I think it illustrates how young we subject people to these things, right? So this is, you know, a 3 to 18 month item for a baby, a sweet baby girl, and it's a diamond ring rattle. And this one is for a busy baby boy, and it is a saw with a mirror, right? So these are all, you know, we are laying our expectations on people around how they should do their gender in so many ways. There's also no difference between these two minoxidils. There's not minoxidil for men and minoxidil for women. They are the identical product. They are the identical strength, and neither one of them is scented. And the only difference is the cost. And the cost for women's minoxidil is higher. So this process is not great for anyone, as I said, but it's really bad for trans and non-binary kids. And when we think about brain development, it's really important that we think about how those things may be landing for people, right? So this experience of just the bathrooms can be really, really traumatic for people. It can be really hard. We have just seen this unbelievable uptick in this assault on trans youth in particular. Anti-trans legislation in 2021 was hellacious, but it's even worse this year. This is from 2021, but I think people are probably aware that the kind of assault on the medical care of trans youth has ramped up significantly in the past handful of months. And then just this week, the Florida Health Services put out a guideline that even social transition or the changing of clothes, name, and pronouns should not happen for minors. Probably a lot of you understand that this process of brain development, much of it, the biggest period of brain development happens in the first 3 to 5 years of someone's life, when you are going from a few neurons and connections to a many. Your brain is just teeming with neurons and connections at 6 years old. And then when you go into adolescence, that's the second largest period of brain development, but the process is called synaptic pruning, whereby your brain is engaging in a process where it is creating neural grooves. And so some of the things that will be utilized or with you for the rest of time are happening during adolescence. And why is this so important? This is so important because if you are developing your brain around the message that who you are is not okay, who you are is not okay at grandma's, who you are is not okay at Target, who you are is not okay at school. Now the legislation is saying that anyone trying to help you can be a felony. Your parents might get in trouble for affirming your gender. And you are growing up with that, and maybe you are getting bullied at school, and maybe you're getting sexually assaulted, and maybe you're getting discriminated against by even teachers at the school, or maybe you go to a doctor or a therapist, you have a terrible experience, someone is belittling of you and your gender. Your brain is developing in that environment. And so if you think about this experience, these collective experiences that young people undergo, it's probably not surprising that you see some of these young people in your mental health clinical services. And we're going to keep talking about that. But if you can wrap your head around the way that chronic trauma impacts people, it is easier to understand why gender dysphoria is so dysregulating. So this was really driven home to me. I had a 4-year-old who came into my office. This is a kid who came in presenting like we might typically expect a 4-year-old boy to present. And we kind of talked a little bit. I asked this mom why she had brought her kid in to see me. And she said, well, we're here because my kid loves to wear dresses and play with dolls. And this tiny 4-year-old child jumped up and put their hand over their mom's mouth and said, don't tell the doctor. And And in that moment, what I realized was, here's a 4-year-old child who already is experiencing shame about what they like. And the point is not even whether the kid is a girl or a boy or non-binary or whatever. The point is that this kid is now developing their brain around this message that they've been given, either directly or indirectly, either covertly or overtly, about the things that they love being unacceptable and certainly not acceptable to the doctor. And that kind of internalized shame really directs somebody's developmental process. So gender identity is developing for trans and non-binary folks within this cis-normative environment. And so there's likely to be a lot of negative messaging that is experienced by these young people. And it is also true that because we're in a cis-normative environment, there aren't pathways that are presented for trans and non-binary people, right? And because of that, the puzzle comes together differently for each individual. Right? Why is that important? Because sometimes what happens is, if a 4 or 5-year-old is talking about their gender, they'll be met with, "You're too young to know." And if a 14-year-old is talking about their gender, then "Why didn't you tell me when you were 4?" So we have these kind of benchmarks that are inaccurate that we load onto people. And I think, I'm a big, I believe a lot in pictures, and I think about, like, for cisgender kids, this is how they grow up. They don't really have to have a conversation about their gender because everything's in place for them. Everything's set up with the expectation that their gender is going to align with their assigned sex at birth. But for the much smaller number of people who are trans or non-binary, they are having to swim upstream. They're having to figure it out. And the capacity of someone to put their gender puzzle together is going to be hugely variable on so many things. That person's temperament, the kind of parents they have, the parenting style, where they live, if they're in, what their culture is, what kind of religious community are they in. All of those things are going to play a role in how somebody figures out their gender. So what happens sometimes for parents who have gender non-conforming children, right? What did we do wrong? How can they know this about themselves? What if we are wrong to support our kid? What will people think of us? Who will love my child? And will this destroy our marriage? And then there's another piece about, like, what will our religious community think or do? And then will my child be harmed? And these are really the common things that people get very concerned about. And because of that, these various and assorted approaches to gender nonconforming children and youth as well have kind of been outlined in the literature, but also in practice. And I know that I'm not going to spend a lot more time on children because it's very unusual for people to actually be vocalizing about their gender when they're a child. There are many adolescents and adults who will say, "I knew something was happening when I was a child, but I didn't necessarily know what it was." But I do want to talk about this because even for adolescents, we see people engaging in these sort of three basic mechanisms of addressing this, right? So reparative and conversion therapy, just briefly, that's sort of aimed at talking someone out of their gender. The wait and see approaches can involve, like, "Oh, well, you can do what makes you feel best at home, but once you leave the home, you have to do conforming in your appearance and assertion of your gender." And then the affirmative model, which may or may not include a social transition. And the affirmative model is sometimes the end result of the wait and see approach. So many of and I had to take out a lot of slides on this, but reparative and conversion therapy is actually not legal in 20 states across the country, where it's not legal to be practiced by someone with a license, but that does not mean that it can't happen through religious affiliations, which is where most people would go if they were in a state that did not allow conversion therapy by licensed professionals. But it's also the truth that many states do not have a ban on conversion therapy. And so you can send your kid out of state. I'm in California where it is illegal, but there is a whole swath of the country where it's not. So it's still happening. And it sometimes involves kind of punitive measures. Sometimes it involves like rewarding measures, but much of the time it's punitive and it's damaging. So these two sort of ways of responding. So if a child expresses atypical gender interests and the parent suppresses that authentic expression, what happens is that you get an anxious and angry child who is at higher risk for negative health outcomes, both physical and psychosocial. On this side, if you have a child who expresses atypical gender interests and a parent who's willing to explore what that means to that child, you usually have a more adjusted child, but honestly, a more anxious parent. But we do that all the time as parents. We take on a lot of stuff so that our kids can be more well adjusted. So this model of gender dysphoria is really important. And it's important to know that gender incongruence is not the same as gender dysphoria. Gender incongruence, or the experience of being trans, is simply that your gender is not aligned with your assigned sex at birth. Gender dysphoria is the distress that can arise from that incongruence. So does it mean that there are some trans people who don't have gender dysphoria? Maybe. I don't have those people in my practice because the people that are showing up for medical interventions have some level of distress and are seeking medical interventions. But there are a lot of factors that can either mitigate or exacerbate gender dysphoria. And some of them are more distal and some of them are more proximal. The distal factors are, what's happening in the society at large. So right now, the last handful of years where the legislation that has butted up against affirmation of trans youth has caused a lot of problems for people. So what's happening in the culture, what's happening in the legislation, what's happening in your larger religious community, and then a little bit closer to yourself, what's happening within your family, what about your own partner, what about your friends, what about access to care, support groups, all of those things can exacerbate or mitigate gender dysphoria. And then the internal pieces are the more proximal exacerbators or drivers or mitigators is one's internalized transphobia, an individual's own process of grief or whatever they're experiencing after they figure out what's going on around their gender, a sense of uncertainty or unfairness, but also their own cultural and religious beliefs. And then there's a lot of fear because it's scary and it's real that trans people have to worry, especially as we've gone on with the legislation and that trans young people have become, in some ways, the focus of the culture wars in the most handful of years. So, ideally, what we're aiming to do, and this is part of the clinical practice of taking care of young people, but also in the research, what we're looking at is, do medical interventions improve mental health and behavioral outcomes? So anxiety, depression, social isolation, we're going to talk about all of these in a minute, but then ultimately we are aiming to improve people's quality of life, their body esteem, their coping, and their life satisfaction, as well as their function. Oh, I'm so behind on time. I'm sorry. Also, an important concept about gender is that you can't isolate somebody's gender from the context that they're existing in. So there's you, the individual in the middle, and they are sending information to the world around them about their gender. Maybe it's, I'm not a girl, look at my flat chest, look at my facial hair, listen to my voice, notice the bathroom I use. And they're getting information back from the world around them about their gender. And so it is really important for clinicians who are doing this work to understand the complication of this experience, of this relationship, and it's the bidirectional nature of it. So let's talk about interventions. So there's a couple ways that you can kind of categorize or lump together interventions. So for prepubertal youth who have not yet started puberty, there are no medical interventions. I cannot stress this enough, because this is something that I hear all the time from people who do not want us to be doing care with youth, as they think that children who have not yet started puberty are getting medical interventions. That's just not true. They're not getting surgery. They're not getting blockers. They're not getting medical interventions. Once somebody starts puberty, they may have gender dysphoria that necessitates puberty blockers or GnRH analogs. And then as they get older, gender affirming hormones and surgery. Another way to conceptualize medical interventions are through the phases of reversible, partially reversible, and permanent transitioning elements. So in the reversible side, you have the elements of social transition, which include changing your clothes, your hair, maybe the things you're playing with, your name, your pronouns, and also puberty blockers. So all of those things are not permanent, and they can be reversed. Once you start adding hormones and some surgeries, there are elements of hormones that are partially reversible and some that are permanent, and then genital surgery is usually considered permanent. And we'll go through these things. This is what I see when I think about the ways that people are presenting to care. There's a couple of stories that I see a lot of repeating. So sometimes, on the rare occasion, about 10% of our clinic are people who are coming in pre-pubertally, so they're young children. They may or may not have had a social transition in childhood. They were talking about their gender very early on, at the age of 3 or 4. Maybe they had parents who were listening, and maybe it was the best thing for them to have a social transition and live as their authentic gender. In the time between when they socially transition and puberty, they have a bit of a honeymoon. And then when they hit puberty, they have to go through a process of integrating and understanding what it means to be trans, which is a little bit backwards from people who come out in adolescence and adulthood. So for trans masculine young people who come out, or whose gender is emerging, or their gender dysphoria is emerging in adolescence, often are described by their parents as having really happy childhoods. Oh, this person was so great. They were getting straight A's, and then we don't know what happened. But at around 11 or 12 years old, they really started doing terribly. They were failing classes. They were isolating. They didn't want to do any of the things they'd used to do. And a lot of these kids will go through a year or something like that where they're working really hard to make girl work. And it's usually happening in middle school, because conformity is really important in middle school. So maybe it's like, oh yeah, I wore girls' clothes and makeup, and it was total fail. And then I really started learning about my gender, and then I came out. And so that process of figuring out what's going on with your gender is, we sort of affectionately call the process of coming in, of sort of exploring and trying to figure out what's going on with your gender. And that process is private. And this is really important, because when somebody is going through that process before they are disclosing their gender, that can look like, oh, my kid's always online all the time. My kid is grumpy. Because you're not, as a parent or a provider, necessarily being invited to that process. You don't get invited in until that person comes out. And so everybody that I've ever worked with in this field has had that's come out in adolescence, has had a process of coming in. And that matters, because it matters for the timeline. For trans feminine young people, I hear this a lot. I had an awkward childhood. I always knew something was different about me. And then the process of coming in, and then sometimes those young people or adults have a period of really trying to make boy work. And you'll hear like, oh, I tried to join ROTC or something like that, that has kind of a masculine flair to it, and generally is unsuccessful. So what are the criteria? You probably all know this, but I think there's some things that would be useful to draw our attention to. You have to have this criteria A1, right? Which makes sense. An incongruence between your experience or expressed gender and your primary and or secondary sex characteristics. And and importantly, in the subheading for the A criteria, this incongruence between your experienced or expressed gender and your assigned gender of at least 6 months, right? And so it really is important that when we start to listen to the way that people talk about this work, making up names like rapid onset gender dysphoria, that we understand that this diagnosis is not even made until someone's had symptoms for at least 6 months. And I have to say that in the context of my clinical practice, I rarely get someone in front of me that has not experienced gender dysphoria for 6 months. And usually it's way longer than that. So they have to have two of these things. So this incongruence between your experienced gender and your primary and or secondary sex characteristics, a strong desire to be rid of your primary and or secondary sex characteristics because of this incongruence, a desire for the acquisition of the primary and or secondary sex characteristics. And for there's more, hold on, a strong desire to be of the other gender, a strong desire to be treated as the other gender, a conviction that you have the typical feelings and reactions of another gender. And then this B criteria, which is that these symptoms create clinically significant distress across areas of functioning. So for folks who are familiar with the childhood diagnosis is largely not about physicality and physical bodies and primary and or secondary sex characteristics. It's largely about sort of who you play with, the toys you play with, et cetera. And so it's a very different set of diagnostic criteria. I think for adolescence and adulthood, the focus is on physicality because this diagnosis is really, in some ways, what guides people to make recommendations around physical or phenotypic interventions. But there are some parts of it that are confusing to me. Like you think you have the typical feelings and reactions of another gender. And I've sort of that's always been a question mark because I don't really think feelings and reactions are necessarily gendered. But that's always been a question mark to me about these criteria. The onset of puberty is horrendous for a lot of trans young people. There is a disproportionate amount of social isolation, depression, anxiety, self-harm, maladaptive coping, suicidality. And one of the things, if you can frame it or think about it in this way, is like you're getting an adult version of a body that you don't necessarily resonate with, and you have an understanding that those changes are going to get you gendered in a certain way because of what I was talking about earlier, the way that we have social cues based on our physiology. And so that is incredibly dysregulating for people, and people have a really hard time kind of envisioning their future in that embodiment of their physicality. And so it leads to a lot of these pretty significant mental health challenges. This is a case presentation. I think cases help us, wrap our head around what happens in our clinical practices, but this patient was a 10-year-old who was assumed female at birth. This kid had socially transitioned at 5, and he had started getting chest development 5 months prior to this particular visit. And this kid would not come out from under his bed because he did not want to go to school because he had this early chest development, and his anxiety was skyrocketing. So this was a kid who had endorsed his gender very early on. Parents had affirmed it. He had been socially transitioned living as a boy. And when he got to puberty, his sort of honeymoon ended, and this was really dysregulating for him. In some ways, these cases are super easy. These are really easy. This is a kid who's obviously too young for hormones, but would be a good candidate for puberty blockers. The goal of puberty blockers is to downregulate the receptors on the pituitary gland and shut the signal off for the body to make sex steroids. So I don't want to go into a huge anatomy lesson, but the way that puberty works is that the brain, the hypothalamus and the pituitary gland signal to the gonads, in this kid's case, his ovaries, and tell his ovaries to make estrogen and progesterone. And those go on to create breast development and menstrual cycle and the other changes of puberty, secondary sex characteristics. So GnRH analogs really were initially designed to be used in kids with precocious puberty, early puberty. So someone starting puberty at 4, 5, or 6 years old we do not want them to go through puberty at that age. So we utilize GnRH analogs to shut that signal down. And we also use these medications in adults and adolescents who have other medical issues like endometriosis or prostate cancer, things where we do not want the gonads to make sex steroids. So these work very well in people with ovaries and in people with testes. We've been using GnRH analogs for 50 years. They have a really very good, enviable safety profile and low side effect profile. So their use in youth with gender dysphoria started in the Netherlands in the late 80s, early 90s. And really, when they published the Dutch protocol in 2006, we started using puberty blockers for gender dysphoria in the US in 2006. So I think of puberty blockers as having a couple of functions, but as I said, I like pictures. So here's our youngster who's starting puberty and feeling very dysregulated. And there are these sort of pathways of physiology, because physiology in some ways, especially if someone's taking exogenous hormones, is very binary. And so puberty blockers really allow someone a chance to pause and not move down either of those pathways. Because a 10-year-old is too young for hormones for a variety of reasons, but blockers are a really good option. And we're a really good option for this kid who went on to puberty blockers. So they are reversible. If somebody is on puberty blockers and they stop them, they will pick up their endogenous puberty where it left off. It may take a little time for their body to start going again, but they will pick it up. It can prevent the development of unwanted secondary sex characteristics, maybe even potentially prevent future surgeries. They can buy time for that young person to think about the myriad of things that you have to think about if you are a person with a gender different than your designated sex at birth. And people can participate in not just therapy, but also their life without worrying about going through a puberty that feels wrong. And so if you are consistently worried about that, and that's taking up 95% of your brain space, your capacity to participate in school and other things is really impaired. Puberty blockers come in two different forms. So they come as, you can either have an implant. It's a tiny, about 1.5 inch long, flexible rod that gets put into your upper arm, or it can be delivered through injections. Both of these are extraordinarily expensive. Okay. Let's talk about gender affirming hormones. I want to spend some time on this. Let's start with a case presentation. This is a 16-year-old who was assumed male at birth. At age 11, they started having unrelenting abdominal pain. This kid had dozens of medical studies, scope from the top, scope from the bottom, pill camera, different medications. By 13 years old, no organic cause of their abdominal pain had been identified. Parents sent this kid. This kid was described as coming out at 14 as a girl, and described to me as very defiant, several episodes of running away, suicidality, self-harm, depression, and anxiety. This kid had been sent to a residential program in Utah. And during that stay, there was a psychiatry report that was 27 pages long, and there was a singular line about gender. And that is how this kid ended up in my clinic, because there is this line about this person is endorsing a different gender, a female gender. And this case kind of encapsulated a lot of the questions that I hear from parents all the time. So they're a teenager, they can't make a decision this big. What if they change their mind? Everyone around my kid is trans, and that's what's causing my kid to be trans. And in that case, this young person had been involved in a relationship with a girl who identified as a lesbian, and the parents felt very strongly that that relationship was causing a scenario that made this kid endorse a female gender identity. Hormones are terrible for your body. Hormones will cause cancer. Hormones will eradicate fertility. These questions or ideas are the umbrella for all of the questions and concerns that people have, that I have heard. So a lot of times, people will say like, oh, this is a really big decision. I really need them to wait. And so maybe someone's in my office and their parent or guardian is asserting they should wait until something. And the benchmarks are different for different people. They might be, finishing high school, fully myelinated brain, lots of different things that people assert that people should wait for. And the issue is that waiting period, there's stuff happening, right? So that young person is experiencing either an ongoing puberty or a longer time of being perceived in the wrong gender, and that is continuing to imprint on the brain and impact how they're going to function. And so, I like to think about this in a different way where, it's important that people recognize that people aren't making a decision about their gender, right? They're not deciding their gender. They're deciding what to do with it if it's different than their designated sex at birth. And that can put the decision making into a very different framework, right? Because when you think about conceptually somebody deciding about their gender, it's very nebulous. It feels very confusing, especially for cisgender people. For us, we didn't decide our gender. We just rolled right into it, right? There was never a question. And so we can't even conceptualize really what it means, the idea of someone deciding their gender. So really, if we sort of anchor this as like, well, people know their gender, they have to make a decision if they want to do something about it, if it isn't aligned with their designated sex at birth. And then if they do want to do something about it, what do they want to do about it? And that can help us as providers of this care in thinking about what that decision making entails. I just want to talk about just really quickly, teenagers do a lot of silly things. They make some bad decisions. And we know this, that they particularly make those decisions in the presence of friends. And so as their emotional brains are ramping up, and as you move into adolescence, your reward centers light up. And so sometimes adolescents will make decisions based on real or perceived rewards. So they'll do silly things that maybe they get a lot of peer reward for, or, maybe they're obvious rewards, like you get high if you choose to do drugs. But it is really critical to understand there is no reward for being trans. And I'm going to explore that a little bit later, because I think that's somewhat nuanced now compared to 16 years ago. But you can see that there's just so much. These are things that people see when they're online, right? There are no transgender kids. There are mentally sick parents only. When my son was 6, he wanted to be Thomas the Tank Engine, right? Like, these are things that people see online. This is just from not even a year ago, when all the nerds died, all the trans people appeared. Is this coincidence? And this is, an article written, "An American mother mourns the loss of her nerdy teenager in the transgender tsunami," right? So this is what people are seeing. And I think that is really important to consider. So we hear a lot about this, and I want to talk about it because it's important. Teens are becoming trans because it's trendy, expert says, right? So let's talk about what this means. I feel like the iteration of this in 2022 is all of my kids' entire Girl Scout troop is endorsing a different gender. So how do you explain that, doctor? How do you explain what that phenomenon is? And what I can tell you is that there is a movement right now in the younger generation to redefine and talk about gender in a different way, in a way that is more culturally relevant for them, in a way that makes sense in how they think about the archaic nature of traditional gender roles and gender expectations. And it may be that somebody's friend group is a large percentage of them are endorsing a different gender or wearing different kind of clothes. But those are not kids who are coming in with gender dysphoria. Those are kids who are enacting and exploring and playing with gender so that they can define it in a way that makes sense for their generation. And this is really important. This is how my 15-year-old described what's happening in the world of 15-year-olds in recreating gender. Gender bending is very, very common, and it's not just a youth thing. This is something that we're seeing in adults, in gender expression, in the way that people are talking about their gender possibly, or just in the way that people are deconstructing gender expression and our expectations around it. In the lower left-hand corner, there's a picture of a K-pop band, and all of those young people are designated female at birth. So I have no idea if any of them identify as boys or men or something other than girl. But I just think that this is a great way to demonstrate that this is a movement, and this is not that suddenly everybody's trans. I think that when we talk about decision making, people are deciding if they want to do something about their phenotype, their physicality, and if so, what. When we think about the elements of decision making, think about these things: bodily autonomy, the capacity for consent and certainty. The capacity for consent is really a functional assessment, right? So it's a clinical determination that a clinician makes about someone when they're involved in this conversation. So there are critical elements about capacity for consent. The first one is communicating a choice, so that the patient or client needs to be able to express a treatment choice. What do they want? If they, and this is critical too, I especially think for gender work, changing the decision in and of itself would not bring a patient's capacity into question as long as that patient was able to explain the rationale for the switch. The second part is understanding. The patient needs to recall conversations about treatment. They need to make this link between sort of, if I do this, what will happen, and then process the probabilities of the different outcomes. Appreciation. So the patient, in this case, we don't call being trans an illness, but the condition of having a gender different than your designated sex at birth. What are the likely outcomes that will affect that person directly? And then the rationalization or reasoning. So the patient should be able to weigh the risks and benefits of the treatment options, doing something, not doing something. Is that aligned with their goals and their best interests? And those are defined by the personal set of values. So let's talk about certainty, because this is an area that is very, comes up a lot in this work. Who is actually trans? How do you know that someone's actually trans? And early on in my career, I thought, I wish we had this. That would make all of our lives so much easier, but we do not have this. And so because our gender is a subjective telling of self, it is more important to focus on the conversations around how people want to wear their gender, how they want to express their gender, rather than focusing on who is actually trans. And I think that can help center us a little bit more. I was reading Ursula Le Guin's Left Hand of Darkness, and this paragraph really resonated with me. There's really only one question that can be answered, and we already know the answer. The only thing that makes life possible is permanent, intolerable uncertainty and not knowing what comes next. And I thought that felt really applicable, because it is absolutely impossible to predict the future. And that doesn't mean that we shouldn't be having very important and very detailed, nuanced conversations with people as they are trying to consider decisions around their physicality. As mental health providers, these symptoms are probably going to seem very familiar to you. Internalizing and or externalizing stress reactions that as a result may create significant depression, anxiety, or anger. So those are very common. That's very common in youth with gender dysphoria. It's also common in youth with autism. It's also common in youth with ongoing prolonged trauma, complex trauma. The inability to plan ahead, anticipate the future, and act accordingly. Common in gender dysphoria, common in people who have experienced complex trauma, but also common in people with ADHD. The struggle with self-regulation or knowing how to calm themselves down, very common in ADHD, very common in autism, very common in gender dysphoria, and very common in complex trauma. Lack impulse control or the ability to think through consequences before acting, very common in ADHD and in complex trauma and in gender dysphoria. Easily overwhelmed, same thing, gender dysphoria, autism, trauma. Emotional responses that are unpredictable or explosive, ADHD, trauma, gender dysphoria, autism. Body dysregulation or sensory dysregulation, very common in gender dysphoria, very common in autism, very common in trauma. Beliefs about themselves, others, and the world diminish their sense of competency. ADHD, gender dysphoria, autism, trauma. Limited language to express feeling states, autism, trauma, gender dysphoria, and view themselves as powerless or damaged, may perceive the world as a meaningless place in which planning and positive action are futile, autism, trauma, gender dysphoria. I put these here because this collection of diagnoses is so common in this population. And there are absolutely people who have gender dysphoria and are autistic. There are people who have gender dysphoria and have ADHD. There are people who have gender dysphoria and have experienced complex trauma. But I also think it's important that if we conceptualize gender dysphoria as ongoing and complex trauma, it's not surprising that these are the two common diagnoses that fit with these symptoms. So we're thinking about complicated. A lot of times people will come in with anxiety, depression, or symptoms of ADHD, high functioning autism spectrum disorder, oppositional defiant disorder, OCD, and there's a sort of idea that this is creating gender confusion for people, and really so many times this is putting the cart in front of the horse. And it is more common that gender dysphoria creates the symptoms of these different entities. And again, this doesn't mean that there aren't people who have gender dysphoria and ADHD or gender dysphoria and OCD. But it is important to have these conversations to kind of distinguish these entities from each other. And really, a lot of times people will say, well, what about first do no harm? You know, what about regret? What about medical side effects? What about cancer? What about infertility? But the assumption when people ask this is that doing nothing is no harm, right? So on this other side, we have this myriad of things: behavioral problems, depression, substance use, anxiety, school failure, high-risk sexual behavior, self-harm, sometimes suicidality. And it isn't the assumption that doing nothing is not doing harm is incorrect. So doing nothing can be really harmful for a lot of people. When do we start gender affirming hormones in our clinic? Well, it's not the same for everyone. It's different for everyone. We consider a handful of things when we are helping make recommendations. Some of those things are the level of dysphoria that someone has, a good understanding of treatment effects. We want people to be able to provide consent for care according to those things that I just talked about. Peer concordance plays a role. The presence or absence of a support system is really important. And then there's physiologic considerations as well. You know, starting hormones is not like shooting a bullet. Someone isn't making one decision. You have to make a decision every single time. You either take a pill, put on a patch, stick a needle in your body, and taking the energy and the gravitas away from this one decision can be really helpful for people to digest and understand what this process is like. Remember that physiologic dysphoria may reside in some of the things that I showed you an hour and 15 minutes ago. So for trans feminine people, it might be their deep voice. It might be the presence of an Adam's apple. It might be their facial structure. It might be their genitals. It might be their facial hair. It might be their stature. It might be the size of their hands and feet. For trans masculine individuals, it might be their higher voice pitch, their menstrual cycle, their chest contour, their stature, their hips. And for non-binary people, it may be a mix of these things or none of these things. So it's not going to be the same for everyone. You know, there is some great artwork where people have drawn what it feels like to have gender dysphoria to that individual. And these are pretty powerful illustrations of folks that were asked to draw their gender dysphoria. And this one, I really appreciate this one because the dysphoria is this giant monster, and here are all the elements of it, you know, like hair loss, my leg hair, my chest hair, my beard, my wardrobe, my skeleton, my big feet, my dead name, you know, me accidentally misgendering myself, my height, not having hips, flat chest, my voice. this is this person's genitals down here. And then their homage to themselves and sort of the defenses that they have, you know, the tic tacs, which are the beginning of breast development from hormone therapy, and then my friend's love and support, right? So this is what's bolstering this person against this giant monster. The goals of gender affirming hormones are to masculinize or feminize bodies. It's pretty simple, but the larger goals, of course, are to improve quality of life, improve body esteem, decrease gender dysphoria, diminish anxiety, depression, and maybe even decrease high risk behaviors. So for trans feminine people, again, just a reminder of what we're talking about: people designated male at birth who identify as female. The feminizing process is relatively simple. You have to block testosterone and you have to induce female secondary sex characteristics. In order to block testosterone, you can block the production of testosterone with a central blocker, or you can use a medication called spironolactone, which acts as both a central blocker and as a peripheral blocker. So you can actually use medications that sit in the testosterone receptor so that testosterone is being made by the body, but it's not active. So spironolactone and bicalutamide are two medications that work at the periphery as well. We use bioidentical estrogen. 17-beta estradiol is the kind of estrogen your body makes. It is the most potent of the three forms of estrogen that your body makes. And it comes as a patch, it comes as an injection, and it comes as a pill. And people can choose which mechanism of delivery works the best for them. They can switch mechanisms of delivery. What are the permanent effects? Oops, sorry, let's switch by that one really fast. So breast development after about 6 months, if somebody were to stop estrogen, they would still have that minimal amount of breast development. The effect on sperm production is very poorly understood. I think more studies need to happen for us to understand exactly what happens to sperm production over time. I can tell you, though, that there are many people who have been on feminizing hormones for a long period of time, and then they stop and they either do cryopreservation of their sperm or they use their sperm to impregnate a partner. And then there are some things that are dependent on ongoing hormone administration. So body fat redistribution, softening of the skin, slowing down of facial and body hair, and breast fullness require ongoing use of estrogen. So for my patients, what I tell them is that the effects are variable, just like anyone going through puberty. What you're going to look like after that puberty is hard to guess. The effects will be variable based on familial and genetic tendencies, and also someone's age, because the younger someone is, the more hormone receptors they have. And the more hormone receptors someone has, the more changes they're going to get. Younger patients generally obtain better and more rapid results, and people will have noticeable changes within 2 to 3 months, and the irreversible breast development after about 6 months. Feminization happens in a timeline we would expect for puberty. Most breast development will happen in the first 2 years, although people's breasts can continue to grow for 5 years. It's important to set expectations. 25 milligrams of estradiol is not going to, completely feminize someone into looking like a totally different person. And so setting expectations is real. I'm going to show you a picture of someone's breast development after an entire year of feminizing hormones. This is what you get after a year, which for all of the fuss and rumble and concern, that's not a lot of breast development. So it's just setting expectations is really important. So in youth who already went through their endogenous puberty that was dominated by testosterone, feminizing hormones are not going to cause the voice to change. They're not going to dramatically reduce facial hair growth, and they're not going to change the shape or size of someone's bone structure. It's really important for me to check in with my patients about enjoying their bodies and caring for their bodies. If someone is going to get genital surgery, they are much more likely to be able to achieve orgasm post-surgery if they've had an orgasm prior to surgery. This is usually a little bit easier in patients who transition post-pubertally, because most of those patients have had some kind of sexual encounter either with their own body or with a partner. For kids who transition in childhood, this is much more difficult because those young people rarely, they have a lot of dysphoria about the idea of masturbating. No one's ever talked to them about it. And so these are really important conversations. For people who are very excited to continue using their genitals, we need to make some dosing adjustments. It's really not kind for providers not to ask these questions about someone's sexual function, because that's not something you want to take away from someone if they're comfortable there. It's really important to talk about dating and disclosure. We want people to keep their bodies safe, but we also want them to keep their hearts safe. And sometimes there's a proclivity to lower the bar. People will be excited that anyone's interested in them. And for trans women, this is particularly challenging. Trans women who are attracted to straight cisgender men, because there's an overlay of homophobia and transphobia onto the trans feminine and trans women in general. Mental health support. So a lot of times in our current, the way that our care is currently outlined is there's a big emphasis on mental health care before someone engages in hormones, which can be really helpful for people. But the problem is that a lot of times once people start hormones, they disengage in that care. And that can be really, really useful for people as they're starting hormones, because they can't predict things that are going to happen for them as they move forward. Cryopreservation, so fertility is a really important thing to talk to people about before they start hormones. Facial dysphoria, genital dysphoria. So as people's pyramid of needs changes, as they start to feminize their body, they might experience more facial dysphoria, they might experience more genital dysphoria. Having those conversations is important. PrEP, which is pre-exposure prophylaxis for HIV, transmission acquisition. And this is something that I offer to all of my patients, regardless of their gender. I think it's important that people have access to PrEP. HPV vaccines, this is less relevant now, but it used to be that people we assumed were boys didn't get HPV vaccines in childhood. Now that's changed, but it's important for my older patients, if they didn't get HPV vaccines younger, that they get them now. These are two patients that had access to blockers and early hormones, and they transitioned really well. They have the gift of what I call selective disclosure, so they can disclose or not. Josie happens to be very out because she's an actress, and so her story is well known because of the media, but they both have the capacity to make a decision about disclosure or not, which keeps them safe. Let's talk about trans masculine care. So for people designated female at birth who identify as something other than female, this presentation, 13-year-old who was assumed female at birth, came out as pansexual at 12, then is non-binary 6 months later, and now is identifying as male. They had their first period, which is described as menarche in medicine, at age 12. So they've been having a period for 14 months. They started getting really out, they started being very dysregulated at 11, which in hindsight corresponded to their chest development. This is that kid that kind of fits that pattern. They're a straight A student, but started failing in 6th grade. They had had a suicide attempt 4 months prior to seeing me with a history of self-harming. They had been in therapy since 6th grade for depression, anxiety, and ADHD. And the parents are concerned because their kid disclosed their male gender right after their suicide attempt, and all of their kids' friends are trans. So this is really common. This is a piece of artwork that young person drew and allows me to use. The trifecta of dysphoria, this is what I hear a lot of, that it's menstrual cycle, high voice, and female chest contour are the things that I hear most commonly, although I hear other elements of physiologic dysphoria as well. Our goals in masculinizing hormone therapy are to create male pattern body hair, deepening of the voice, increased muscle mass, induction of amenorrhea, which means someone's no longer having a menstrual cycle, and then reduction in chest size or contour. The process of masculinizing, you probably recognize this, that block estrogen production and induce masculinization. The benefit of testosterone is that it's actually excellent at doing both of those things at high enough doses. So when people are engaging in care younger, for this 13-year-old, I would not give a 13-year-old a high enough dose to suppress their own endogenous estrogen production. They would need to be on a central blocker in addition to the testosterone. Testosterone comes as a gel, a patch, or an injectable. It does not come in a pill form in the US because it is really hard on the liver. What are the irreversible changes? So once someone's voice goes down, it's down because your vocal cords grow and thicken with testosterone. Once you start growing facial and body hair, that doesn't stop if you stop testosterone. It would slow down, but it doesn't stop. And then male pattern baldness, a poorly explored aspect of testosterone. And I think that more work will be done on this, but male pattern baldness happens because testosterone in people with testes and people taking exogenous testosterone becomes its stronger form, DHT or dihydrotestosterone, and that's what causes atrophy of the hair follicles. And then genital changes. So when people start taking testosterone, the tissue that we call the clitoris in a vulva is the same tissue that we call a penis. And so when it gets exposed to testosterone, that tissue grows. The majority of that growth is not visible. You will see some change in girth and length, but most of that growth occurs underneath the pubic bone. And then some shrinking and softening of chest tissue. So these are the things that change, but that you have to continue using testosterone to keep them changed. So increased libido, redistribution of body fat, and then cessation of ovulation and menstruation, muscle development, prominence of the veins and coarser skin, acne, alterations in blood lipids, and then increased red blood cell count. And then people sweat more and their body temperature is higher, so they may have changes in their body odor. Again, setting realistic expectations. 50 milligrams of testosterone is not going to make somebody look completely different, right? It takes a while for these changes to happen. This is a young person who is on testosterone for a year. You can see facial hair. You can see that their jawline appears more angular. And their subcutaneous tissue is redistributed a little bit. So for my transmasculine patients, similar, enjoying and caring for their body, dating, keeping their bodies and hearts safe, mental health support, cryopreservation. So if people are interested in harvesting eggs, we have this discussion before they start blockers and before they start testosterone. Cryopreservation is extremely expensive and the process of harvesting is really difficult. So it's not covered by insurance. So it really is differentially available to resourced people. Chest dysphoria, because people's chest dysphoria ramps up pretty quickly, pretty commonly after they start testosterone because their body's masculinizing and there's a differential between their rest of their body and their chest. Genital dysphoria, I've often seen coming on later for people, and PrEP also, HPV vaccines if they didn't get them, and cervical screening. If you have a cervix, the recommendation is that you get it screened at 21. Okay, this is my final slide. And it is just a group of people who had access to early intervention, who have the distinct advantage of being able to selectively disclose, and particularly for trans women of color who are at higher risk for health hazards, for homicide, for violence. The ability to not be identifiable as a trans person is life-saving for trans women of color, but it also makes life much, much simpler for all trans people. And this is why I feel like youth care is so critically important, in addition to giving people a longer amount of time to live authentically. So I'm going to stop sharing, and I know that my time is up. So I want to give people, and I guess, an opportunity to ask questions if they want to stick around. I'm not sure.
Well, first, thank you very much for the presentation. I appreciate it. Obviously, if folks have questions, they can just unmute and ask them, or they can put them in the chat. It sounds like our speaker is willing to stick around a little bit. So if you are willing, we can get a couple of questions answered.
And I'm trying to figure out, is my presentation still up here?
Nope,
Or
you are
no?
up now. Nope, now you are
Okay.
up. Dr. Moravec,
Okay.
Jenna, please.
Thanks so much for all of this information. I really, really appreciate it. I think one of the things it's really going to do is it's putting together thoughts in an argument for me for how to address it with parents, right? I mean, we all kind of have that gut feeling of we know this is the right thing, but you've given us, I think, the ability to put it into words for parents. I had a question, and so one of the things that I've been reading about is the guevadoches. And so I guess my question is really, so I have two. I have one about IVF and cryopreservation. I have one about guevadoches, because we in studying guevadoches, these people who do not have the proper receptors to masculinize in utero end up doing so in adolescence. And everything that I've read has suggested that they make a full transformation and are completely indistinguishable from boys who've masculinized in utero. And so I'm wondering why we can't somehow maneuver more effectively without surgery for them, or if there's something missing in the literature that we're not being told about the ability to fully transition.
So I'm not sure I completely understand your question.
Sure.
I'm sorry.
No, it's okay. So if we have boys who, due to not having the proper receptors for masculinization in utero, if at puberty their endogenous uh, pubertal testosterone hormones can fully transition them to male gender, and in the literature you would presume that that includes genital development and sexual function. It surprises me that we haven't scientifically figured out a way to do that for people who want to transmasculinize.
Yeah, that's a condition that I don't have a lot of familiarity with, but I think that you're right. I think that there are. Well, okay. Let me answer the piece
So is
that
beyond the scope of this lecture?
It's a little beyond the scope of this lecture, but let me just add that I think that the it's sort of thinking about how to maximize the capacity for someone to embody their gender is, has not been, because for so long being trans has lived in the world of mental health. Even though there's an understanding, and there has been for so long, that trans people have existed since people, and then the second piece being that, regardless of whether you think it's a psychiatric condition or not, it's refractory to psychiatric intervention. So what we're left with is changing physicality, right? So we've known that for a long time, but the vestigial tail of this work is it's a psychiatric condition. So the level of rigor and sort of understanding how what you're talking about, the complexities of hormone receptors, and understanding that all bodies start out as with the potential to sort of develop in a myriad of ways. Why can't we do better? That's really a reflection of the feelings of the professional communities about trans experiences. It's like, why are there no FDA approved medications for gender dysphoria? Well, because discrimination goes all the way up to the FDA, right? And so, and within the drug companies, they don't feel compelled to get FDA, indicators for gender dysphoria, right? And so I think that there's so many people ask me this all the time, what is there to do in research? And it's like, well, everything, absolutely everything is open. And so I do think that, that even our understanding of the differences in sex development that we do have, I think we don't extend. I mean, it's interesting, right? As a scientific community, we actually understand that there are many, many trajectory differentials from chromosomes to reproductive tract and genitals, right? That's one of them that we're talking about. But temporally in utero, what follows reproductive tract and genital development is brain development, right? And so why isn't it possible for people to understand that also in the second part of that developmental trajectory, there are also differential trajectories, right? The most common one is if you have a penis and testes and a scrotum, you're going to probably have a male gender identity, and the most common trajectory is attraction to women. But we also know there's an entire community of people who do not follow that developmental trajectory, and so I don't understand why that doesn't live more in the world of science. And I think as long as there's affect or politicization of sexuality and gender identity, it keeps it from fully being in the world of science, if that makes sense. Right? Because we also have this issue of, when you start to examine why anybody's gender identity is what it is, you're down that weird slippery slope of, oh boy, is someone then gonna do genetic testing and like feel a certain way about their, embryo or unborn baby or whatever, and it starts to get weird, and that keeps us from being able to do this, really ask this really important scientific question, which is, where does gender identity live for all of us? Not just trans folks, but like all of us. And so I think more and more people are able to do this, and we're understanding, right? It's in the brain, it's in the way that the morphology of the brain, the connectivity of the brain. But I do think that that's why these explorations of these things are not fully more fleshed out than they are.
Thank you.
Okay. Yeah, thank you. We have a couple of related questions in the chat. Can you speak to the risk of suicide for this population? Any suggestions that you have for how we would address or prevent either guardians or other treatment providers? And then we have another question that's related for references or resources that we can give to parents who adamantly disagree with supporting a transgender, but we need to educate to keep their child from committing suicide or keep their child safe as their child is trans, whether the parents disagree with that or not.
Yeah, I mean, one of the most unfortunate things that happens in this work is that that because of exactly what I was just talking about, the politicization and the uncertainty and the fear and concern about regret, is that we have moved to this kind of mantra of, we have to do this or kids are going to die, right? And we really shouldn't be practicing from this perspective of, we're doing this so people don't die. Like, that's not actually the focus of the work. The focus of the work should really be, we're doing this so people are able to embody their gender in the way that feels the best for them and allows them to thrive, right? And so, but what happens is that sometimes young people, there are people who are, they can't imagine their future, and so their option is dying or trying to die. That there are those people, but more commonly among adolescents, what I see is no one is listening to how painful this is, and so I'm going to try and die. And that's, we need to sort of reframe and help people. And I do this work a lot with parents, of trying to help them understand the distress, the pain that their kids are experiencing from gender dysphoria. Because the weight of gender dysphoria is in the wrong place. The weight of gender dysphoria lies in, are they really trans? When really the weight is the experience, the burden, the heaviness of gender dysphoria that people are having to tolerate every single day. And so helping people, it's not appropriate to be in this stance of blackmailing parents and saying, like, if you don't support your kid's going to die. It's much It's much more important to help parents understand what their child is experiencing so that they don't have to get to a point where they're trying to die, right? That's not a good place for anyone to be. And so it is, I think that that's been leveraged in the past as kind of a go-to, but I don't think that's the way to do it. I think the way to do it is psychoeducation, is explaining to parents about what their kids are experiencing. And what I've noticed is that young people will not share their level of dysphoria with their parents. They are very protective of their parents, and a lot of young people know that their gender is a burden for their parents, and they feel really bad about that. And so they're simultaneously managing, I feel terrible that this is a burden, and this is a really big, a lot is happening for me, and I don't really know how to put language to it. And one of the things that we talk about when I train with my husband and other colleague is the concept of noise, of gender dysphoria noise. So the things that are happening every minute of every day for people. And so this conversation developed from, for folks who don't know, my husband is a trans man, and one day we were in the kitchen talking, and I said, how many times a day do you think about being trans? And he was like, what? And I said, well, like, how many times a day does it come across your, and he was like, what? It's never not there. And I thought, oh my God, it must be so loud. And we started conceptualizing this idea of gender dysphoria noise, what it means for people all day, every day. So, which bathroom am I going to use? Are people going to say something? Does my chest look flat enough? Does it look like I have breasts? Are people going to think I'm a man? Are people going to think I'm a woman? What's going to happen with the sound of my pee when it hits the water at a different time? Am I going to get hurt? Am I going to be able to go out to the bar? What about my name not matching? It's an onslaught of things all the time. And then think about what we're asking people to do. Can you do math? Can you pay attention? Can you be present in these moments? And it's really, really hard for people. So, but they often can't explain that because they've been navigating that their whole lives. And so they can't get out of that in a way that allows their parents to understand. I hope that is helpful
I think
to
Dr.
people
Hirsch
with their
looks like you
hands
have a
up.
follow-up.
Hi, thanks. Respectfully, having worked in California, now working in Wisconsin, I think that there are certainly families and maybe some differences culturally, but we certainly have families that simply don't believe in the concept of anything other than cisgender heterosexual. And we're not threatening them that their child is going to die if they don't accept this. We just need to educate them about, well, you disagree about this. How can we help you agree to disagree? And then how can we help you understand that if you don't support your child, they are going to continue to be depressed? Because I work on an inpatient unit. The kids I
Yes. Oh,
see
so you're in
are
it. Yep.
suicidal and have often attempted suicide,
Yep.
sometimes nearly dying. And so we really have this situation where we get really stuck because parents it's really kind of a life struggle for them that they've never agreed with this. And now they're faced with their child that is saying, their child's not threatening them, their child's not saying you accept me or else, but their child is saying, I'm so unhappy. And then the family can't support them because their whole cultural support, family network, belief system doesn't allow this. So we're just kind of looking for any resources, supports we can give these parents to say, hey, we understand, but whether your child is or is not trans doesn't really matter. Right now, their problem is depression and suicidality. And this is one thing that you can change. And I've actually had these moments where parent who does then start using the correct pronouns.
Yeah.
But just wondering if you have any words of wisdom or resources you could even leave us with. That would be very helpful for these families.
Yeah. I mean, a couple things that can be really helpful is you can walk through kind of the exercise of talking about gender noise as you understand what it might be like for people. Sometimes I will do that for a minute or a minute and a half, and it's just so overwhelming. And then the parents inevitably will look at their kid and say, is that your experience, or is that something that you're experiencing? And that kid says, yes. I mean, because all of those things I'm saying come from the things that kids have told me, right? So it's not like I'm making it up, right? It's coming from their experiences. And so one of that can be really helpful. Another thing can be, and I really appreciate, I feel like I heard you say this, that, you know, if parents can make even small little changes that are reversible, and their kids then become their own data set, right? So it's like, if you use a different pronoun with your kid, if you use a different name for your kid, these are things that you can easily change, right? Or sometimes with littler kids, I'll say, go out for a weekend with your kid somewhere far away. You're not going to run into your neighbor or your dentist, and let your kid express their gender in whatever way feels best for them, use whatever name and pronouns they want, and get data. Understand. If you see, I mean, parents have said this, like, we took our kid out to Disneyland. We used a girl name, and it was the happiest we'd ever seen our kid in 11 years, you know? And it's like, well, that's really good information for you to have. Kind of solidifies like that this is your child's truth and their reality. So maybe for some of those, and I know that I've had, I mean, thankfully not a lot, but I've had a handful of people who are hard stops, right? They can't move anywhere, right? They just can't. And part of setting up resources for that would be dependent on what where people, so some people, they're stuck because of religion, right? And they need a different set of resources than maybe someone who's stuck for a different reason. And so important to like find out, and we certainly have, it's really good locally to find people that are religious leaders that are supportive and affirming of trans experience. And sometimes, like, we have a little cadre of trans folks who are religious leaders, and we call on them to sort of help facilitate these conversations. We actually have a trans man who's in our pastoral services at the hospital, that is really helpful when religion becomes a hard piece. But there also are some books and some articles written about the intersectionality of religion and trans experience that can be really useful. I can drum them up and send them along if that's something that might be helpful. But really identifying what that specific sticking place is really helpful in trying to figure out what those resources might need to be.
Okay, well, thank you for going into overtime with us, Dr. Olson. I think that is the time that we have for our presentation, if not more. So I want to again thank you for taking the time to help us with this. And this is going to be recorded, so please make sure that you let your colleagues know that this is available and has been an extremely helpful conversation to have. So thank you very much. Thanks, everybody. Have a great rest of the day.
Thanks, everyone. Have a great week.